Decades ago, Dr. Paul Farmer inspired people around the world when he began reimagining what is possible when healthcare is treated as a human right for everyone, everywhere. Today, millions of people around the world, students, teachers, patients, clinicians, and government officials are working side by side to advocate for global health equity. Together, they're thinking bigger, acting out of compassion for one another, and moving forward in solidarity to support those often left behind. The Paul Farmer Symposium on Global Health Equity gives us an opportunity to gather with individuals and institutions across clinical care, research, and education. Together, we honor Paul's legacy and explore how we can fight injustice by building health systems that serve everyone. This year, we focus on mental health. In low-income countries, fewer than 1 in 5 people with a mental health condition ever receive treatment. Meanwhile, evidence shows that investing in mental health care greatly reduces suffering and improves the overall health, quality of life, and life expectancy of this vulnerable population. With the right resources, we can meaningfully respond to this crisis, addressing not just healthcare, but the broader social, economic, and structural forces that shape mental well-being. Because, truthfully, there isn't health without mental health. We are honored to continue the work Paul started all those years ago. Guided by his wisdom, we will continue addressing the world's most urgent challenges and driving forward our collective vision of advancing health as a human right.
Good afternoon, everyone. I'm Joe Radigan, the Chief of the Division of Global Health Equity at the Brigham and Women's Hospital. And on behalf of the Event Steering Committee, I would like to welcome you all to the 3rd Annual Paul Farmer Symposium in Global Health Equity. In addition to all of us here together, gathered in this room, there are literally hundreds of folks on the live stream. So welcome to you all as well. This year's topic is Mental Health Matters. Mental health, defined in the broadest sense as a state of well-being where individuals can realize their own abilities and contribute to their community, was something that Paul cared deeply about. One of the core themes throughout his writing is how suffering, which Paul always considered both mental and physical, injures and wounds a person's well-being and damages their social ties. For Paul, this mental and physical suffering was not the result of an individual's behavior or faults, but rather due to forces beyond their control, forces that were often embedded in the structure of society. In a paper he published in the journal Dædalus in 1996, almost 3 decades ago now, that was entitled Suffering and Structural Violence, A View from Below, Paul seeks to address the question that was central to so much of his work. And I quote, "By what mechanisms do social forces, ranging from poverty to racism, become embedded as individual experience?" Despite being an expert in understanding these social forces, Paul's touchstone and ground truth was always the lived experience of those who suffered due to those forces. His ethnographies are written with a deep respect, in fact, a reverence, for the ways individuals struggle daily to endure their mental and physical suffering. To answer the question he poses in the Dædalus paper, he describes the life histories of 2 impoverished Haitians living in the Central Plateau. And he documents the myriad ways their lives were diminished and cut short by forces beyond their control. To quote Paul again from the paper, Asaphi Joseph's and Chuchu Louis' stories illustrate some of the mechanisms through which large-scale social forces crystallize into the sharp, hard surfaces of individual suffering. Such suffering is structured by historically given and often economically driven processes and forces that conspire to constrain agency. For many, including most of my patients and informants, life choices are structured by racism, sexism, political violence, and grinding poverty, unquote. But despite the enormity of these forces, Paul was the eternal optimist and the perpetual clinician. He knew that once one could understand how these forces became embodied and caused suffering, one could then begin to take them out of the body through care and accompaniment and restore well-being and health. And that's the project that became his life's work. Today, as we celebrate Paul's intellectual and moral legacy, it is this process of restoring well-being and mental health that we will hear about from the many experts, speakers with us today. I would like to invite one of the leading experts in global mental health, Dr. Vikram Patel, the Paul Farmer Professor and Chair of Global Health and Social Medicine at Harvard Med School, to speak next.
Thank you, Joe. Thank you. And good afternoon to you all, and welcome on behalf of this amazing community dedicated to global health equity in Harvard. I'm particularly thrilled, of course, as you might imagine, that this year's theme, as we celebrate Paul's life and work, this is the flagship annual event for our department. I'm particularly thrilled that this year the theme is one that's very close to my heart, but indeed has also been at the center of this department's intellectual contributions going back several decades. I'm reminded of previous leaders of our department, Julie Richmond and Leon Eisenberg, through to Arthur Kleinman, Byron Good, Ann Becker, and all the way through to myself today. Leadership in mental health has been at the heart of this department. And I will speak a little bit more about that when I introduce Arthur for his keynote a little later. Friends, we convene for this symposium today in an extraordinary moment in history. In January this year, the new US administration abruptly and cruelly disrupted its commitments to global health and the global health architecture altogether. We saw the decimation of USAID, the withdrawal of the United States from the World Health Organization, the breaking of commitments to many of the shared sustainable development goals that we had signed up to, the attacking of the knowledge economy of science and education, not least here in our own community, and threatening the well-being of millions of poor folks right here in this country. These actions, tragically, were followed by very similar actions by many other wealthy nations in Europe. It must seem to Paul and to all of us that the post-colonial social contract that wealthy nations had established in solidarity with the countries that they had once colonized and with the poor in their own countries has been fundamentally broken. The solidarity between nations, built on the understanding that all of us who share this tiny planet share a common destiny, has been shattered. And wealthy nations, it appears, are once more shifting their attention from health equity and solidarity to the military-industrial complex. I'm sure you'll agree with me that this is truly a historic inflection point. Over the last 6 to 8 months, I've been working with a number of thought leaders concerned with global health equity from around the world, including some of you in the room here today, to try and look through the crystal ball, as it were, to see where this is going to take us. What's the future of the field that Paul and all of us embraced? And while these conversations are still ongoing, it seems clear to me that there are two broad themes that are emerging. The first is that there needs to be a moment in history, and this is the one that nation states take full ownership and commitment towards the health and well-being of their peoples through a fundamental commitment to universal health coverage, moving away from the vertical programs and magic bullets that many donors have loved in a relentless quest for health equity. And second, a renewed commitment by all the nations of the world, and let's be clear, this is the majority of the nations in the world, where 90% of the world's people live, to continue their commitment to the Sustainable Development Goals, especially on the issue of climate. Now, some of you may be wondering what any of this has to do with the theme of the conference today, the symposium today. Well, it seems to me that you could look at this moment as another moment of threat, a threat that issues like mental health will once again be pushed into the shadows. But I prefer to think of this as a moment of an opportunity for us to advocate even more fiercely to make sure that mental health is bang in the middle of these broad conversations. For I'm sure you'll agree with me that healthcare cannot be universal without addressing mental health. And nor can we address the well-being of populations in the context of sustainable development goals like climate without addressing mental health. The program today will illustrate how decades of investment in knowledge and praxis that comes from very diverse fields. I can think historically the fields of social, community, and cultural psychiatry and psychology. I can think of the disability movement that gave us the iconic slogan, "Nothing about us without us," all the way through to my friends and colleagues in the field of global mental health. All of these disciplines have generated knowledge through experience, through practice, through research that point us to very important paradigm shifts that should define our commitments to scaling up mental health care. First, we need to shift from a focus on diagnosis to a focus on caring for the person. Dealing and addressing with what matters to the person, their wills, their preferences. And this, of course, isn't just clinical. Most often, it also embraces the psychosocial. Second, we need to move from a focus on highly specialized clinicians delivering mental health care in hospitals, or rather expand that focus to embracing community solutions, ones that empower frontline workers to accompany people, one of Paul's most evocative ideas, on the journey to recovery. Third, we need to move from a narrow focus on treatment to the all-important goal of prevention. For not in any branch of medicine have we ever really improved population health through a singular focus on treatment. And we know what that involves in mental health. The very fact that most mental health problems begin before the age of 24 indicates that the early years of life offer the most important opportunities for prevention by modifying adverse social worlds that children and young people grow up in. And lastly, to ensure that we move from a paradigm where doctors and other professionals decide how mental health care should be delivered to one that centers the lived experience in every aspect of mental health care, from the design, the delivery, to holding the mental health care system accountable. This symposium offers an amazing program of experiences of speakers who will address many of these themes before you today. And I, for one, am so excited to hear them all. I'd like you to join me in welcoming the first panel, and I will invite the moderator of the first panel to join me here to introduce the panel, Dr. Beppe Raviola.
Good afternoon. It's a privilege to be here with you all. I'm going to introduce our panelists. I'm going to provide a 5-minute introduction to the topic. We're going to get to the questions and discussion. We're going to talk about impact in global mental health delivery and research. Mental health care delivery encompasses public health and clinical care. It encompasses support for people who do not have a mental disorder and people with mental health problems and disorders, whether we call them common or severe. It encompasses research and delivery together, as well as some other domains and areas we'll discuss. I'm going to introduce our speakers in their teams. And so at the center back next to me, you will see Carmen Contreras, Director of Mental Health for Socios and Salud in Peru, who has overseen innovative programs combining mental health, tuberculosis, and social support, demonstrating how accompaniment and task sharing can transform outcomes for vulnerable populations. After over 2 decades of working on various research and initiatives for Socios, she became leader of mental health at Socios 8 years ago. She's developed mental health programs and interventions. She's deeply accomplished, and next year will complete a PhD at Universidad Nacional Mayor de San Marcos. Here she is with us in her team in Lima, Peru. Dr. Teresa Betancourt is director of the research program on children and adversity at Boston College and conducts groundbreaking longitudinal research on child mental health, family resilience, and systems of care in humanitarian and post-conflict contexts. She is Salem Professor in Global Practice at the BC School of Social Work. She's widely recognized for her multiple decades of groundbreaking global mental health research, especially on the well-being of children and families affected by war, poverty, migration, and HIV. She is one of the most influential scholar practitioners in the field of global mental health. In this photo, she is in Nyanza district, Rwanda, with one team engaged in supporting the powerful and remarkable family strengthening intervention work. Dr. John Naslund is co-director of the Mental Health for All lab in the Department of Global Health and Social Medicine at Harvard Medical School. He's an honorary research fellow at Sangath, a world-leading NGO and research organization based in India, and instructor at Harvard Medical School. He is well known in global mental health and digital health for his pioneering work at the intersection of technology, mental health care delivery, and health system strengthening, especially in low and middle-income countries, but with rapidly increasing engagement in the US. He's a leading figure in demonstrating how task-sharing models and digital tools dramatically expand access to mental health services. Here, he is with the Mental Health for All lab team here at Harvard Medical School. Global health delivery broadly describes the practice of implementing interventions to improve healthcare delivery in low-resource settings. By extension, global mental health delivery refers to the implementation of effective evidence-based, timely, accessible, and affordable mental health care in settings with limited formal mental health services, with attention paid to clinical, public health, and social dimensions. Often it requires us to work across three major domains of global health practice: service delivery, training, and education and research, each of which might be practiced by and at different locales or institutions. NGOs, hospital systems such as Mass General Brigham and Boston Children's Hospital have a fundamental role to play, as do universities such as Harvard. 28 years ago, as a first-year medical student here at Harvard, I met Dr. Farmer, and we started our personal dialogue about mental health and psychiatry. Paul had been interested in the field, and as you had heard a little earlier, written an incredible set of works around mental health, including a chapter on the birth of the clinic and the history of psychiatry in Haiti. He was always supportive while questioning. Beyond anthropologists, was clinical psychiatry up to the challenge of global health? Could clinicians in the mental health professions restrain themselves from looking to diagnose the poor? 16 years ago, I started to work with PIH. What always struck me and stuck with me was something Paul said again and again. There needs to be a there. We actually need to offer something real where people live. And so today, let's think about the what. What is the there in global mental health delivery? The what is the first question. At Partners in Health, we talk about 5 S's: staff, stuff, space, systems, and social support. That refers mainly to the what. And then what, and then how. And why do we need to care? This is the 40-person mental health team for Partners in Health in Eastern Sierra Leone, working in Kono out of Koidu Government Hospital. They believe that mental health is a movement. We're asking a lot of them. These are mental health community health workers, 3 psychosocial counselors, not graduate-level psychologists, and 1 psychiatric nurse. They work at the hospital, they get on motorcycles, they ride to the kingdoms, delivering care at people's homes. The there is not just interventions, it is the people doing the work. That goes beyond the what. The interventions are delivered by them, and we want them to be effective. Effective mental health care delivery requires teamwork and collaboration. And this is one aspect that we're getting wrong in the US. We have 52,000 psychiatrists in the United States. Sierra Leone has 1 psychiatrist although we have a second psychiatrist who's just graduated from the National Psychiatry Program that PIH supports. This is a man on a home visit. The woman on the left standing is Kathy Conte, the prescribing nurse. At the hospital, she functions as a rounding consultation liaison psychiatrist without being a psychiatrist. She goes on home visits. The gentleman seated to her right directly is Lansana Kamara, mental health community health worker. To his right is a neighbor of the gentleman receiving care at the center. The neighbor gave him his space in a shop that he owns after his wife passed away. And so the patient lives in the shop. To the patient's right is another neighbor from another home. The man in red to the right is a graduate of the MMSc GHD program at Harvard. His name is Grant Gonani, a district clinical officer in Malawi. He came to Harvard and then 5 years ago became the director of mental health for PIH in Sierra Leone. He is Carmen Contreras' counterpart. Around 2015, we took a look at a 2013 Lancet paper by Jim Kim, Paul Farmer, and Michael Porter to inspire us to develop a mental health care delivery value chain that applies a systems-level analysis to the complex processes and interventions that must occur across a health system over time to deliver high-value care for patients with mental health problems, including community health workers, such as this person, Josiah Fono, part of the team in Sierra Leone and Liberia, where they treated people in their homes, again, in far-reaching places. The value chain, here with key elements taking out, includes what is the most possible clinical interventions at health center and community levels across 6 areas: crisis response, prevention, case finding, assessment, treatment, follow-up, and reintegration. I can show those elements to you later if we have time. We also need ways to communicate about global mental health delivery with each other, respecting the diversity of engagements that exist in mental health, given the extreme need. We feel it's helpful to think about building blocks that include domains of action, areas of focus, philosophies of care, and a guiding ethos, which is health equity, partnerships, collaborations, and teams. The 3 areas of focus are systems of care, humanitarian crisis response, or mental health and psychosocial services, also known as MHPSS, and task sharing, which we'll discuss more. These are not mutually exclusive. We have to marry the public health and the clinical approaches and not keep them separate. To develop a continuum of care, we need both working together. Important to say that it's difficult for any single organization or entity to embody and carry out the work of all of these. So for example, at Partners in Health, it may seem that we've had to focus primarily on service delivery and clinical approaches, but we need partnerships to effectively focus on all. This kind of framing of the work with the value chain and other tools for our teams helped us to expand access to care at all 10 global sites. You can see over the past 4 years, we've had significant reach. But we don't want to overreach and then burn out the wonderful teams who do the work and which have limited human resource capacity. So it's a balance between reach and being responsible. Humility is required or there will be unintended consequences. Similarly, we've had significant expansion of psychotherapy and psychosocial interventions delivered by non-specialist providers. This is good, but psychotherapy is difficult. This is where technology can help us more, and we look forward to leaders such as John, Vikram, and others here among us to help guide us, because technology will be critically important as we move forward together. This is an example of a psychosocial intervention that we don't consider clinical. This is the World Health Organization Problem Management Plus curriculum. 4 skills in 5 sessions: relaxation, problem solving, giving hope, and strengthening social supports. Our sites use it enthusiastically, and this line between what we call a clinical intervention is interesting to consider. Taken together then, our work has covered all of these building blocks. And there's many exciting things that have happened, but one in particular is that we will be opening a new department of psychiatry at the University of Global Health Equity this year, a residency training program in 2027, and I'll also mention that the Zanmi Lasante mental health team in Haiti has worked to increase access to mental health care over the last 4 years, and new research from Dr. Eddie Charles, here in the MMSC GHD program, is showing that service delivery increased and did not decrease over the last 4 years in Haiti. At most PIH sites, we've worked to develop a decentralized continuum of care that is a viable alternative to psychiatric institutions, and the work in Rwanda stands out for its comprehensiveness and has even been highlighted as an example of where the US might go and emulate. Lastly, I want to mention a collaboration here in Massachusetts with the Family Van. Before COVID-19, followed by our engagement with the Commonwealth of Massachusetts during COVID, this led to a partnership with the Family Van and the Blue Cross Blue Shield Foundation to capacitate community-based organizations to deliver care outside the health system here. The Family Van has become expert implementers of the Problem Management Plus intervention, creating a program called Healthy Roads. And last week, we gathered with the other organizations we've trained, and we had wonderful presentations on this work. One example, the Cambridge Economic Opportunities Committee, Cambridge's designated anti-poverty nonprofit organization, who adapted lessons from global mental health delivery to the US context. So we'll hear more about this work on our panel, and I'll now welcome our speakers and our panelists. Thank you. Welcome. Okay, let's start with systems of care, service delivery, and equity. How does your work focus on integrating mental health care into existing systems so that prevention, psychosocial support, and treatment coexist? And how do you ensure this integration advances equity rather than reproduces inequities? Carmen.
Good afternoon. My name is Carmen. I work in Peru, in one of the most vulnerable areas of Lima, called Caraballo, where health inequities are very common, even though the public health system is present. It is still not enough to respond to the multiple needs of the population. For the past 29 years at Socios en Salud, we have been working hand in hand with the public health facilities. We started by supporting people with tuberculosis, accompanying them through their treatment and addressing their mental health challenges, such as depression, anxiety, and stigma. But soon, we realized that focusing only on one disease was not enough. People were facing many other challenges that affected their overall health and well-being. So we expanded our work to other groups, people living with HIV, pregnant women, children and adolescents, women survivors of violence, migrants, people affected by COVID-19, chronic mental disorder, and more recently, elderly people. In every case, we integrate mental health into existing health services. We apply evidence-based intervention recommended by the Minister of Health, the World Health Organization, and academic partners. From screening and psychosocial support to brief community-based treatments. We make sure that this integration promotes equity by working directly in the areas where the gaps are greatest. We strengthen local capacities, empower community health workers, and ensure that each intervention is culturally appropriate, accessible, and free from discrimination. In this way, we aim to make mental health care not a privilege for a few, but a fundamental right that is fully integrated into the health system and the daily lives of the people we serve.
Dr. Betancourt.
So, can you hear me? So, I'm Teresa, and I am going to talk today about the perspective of working in war-affected settings. I've been working in Sierra Leone since 2002, since the end of the war there, and also in Rwanda since 2006, after the 1994 genocide. And as you can imagine, globally, when we think about populations affected by armed conflict, the amount of trauma, loss, life disruption, the mental health needs are great. Unfortunately, in most war-affected settings, we're not really reaching families, youth, and children, and all populations with evidence-based services. And I've sort of made this my mission, especially in the 23 years of work in Sierra Leone, or I'd like to highlight what we've had to do in terms of innovation. So you heard from Beppy that Sierra Leone still today has one psychiatrist. That was the case in 2002 when I showed up there after the war working with the International Rescue Committee. And with really little in the way, and the psychiatric hospital reforms that Partners in Health have done have been amazing. But in terms of community-based mental health services, there's been very little. And we had to think of other platforms for delivery that would have reach. And if the health system can't reach, what are the alternative ways to find children? Well, one of our earliest studies was to integrate evidence-based mental health interventions into school settings, done by non-specialists, but linking to the platform of schools to see if non-specialists could improve the mental health of children. The intervention that we were using, very similar to the WHO problem-solving therapy, is called the Youth Readiness Intervention. We were drawing common practice elements from cognitive behavioral therapy, group interpersonal therapy, mindfulness-based practices, and also looking at functional impairment. And what we found is when we screen kids who are out of school and going back into these accelerated education programs, when delivered by non-specialists, we could improve mental health, improve functioning, but also there was a knock-on effect to that life opportunity, which was education. So we saw kids who got the evidence-based mental health intervention were 6 times more likely to persist in school. And teachers in a cluster randomized trial who didn't know who were in the intervention group or the control group, they saw better classroom behavior, better preparedness for school. So this got us thinking, okay, if we can do this in schools, what about other platforms for delivery? If Sierra Leone's not reaching young war-affected people in the community, what is? And we were able to write for an NIH grant a few years ago for, and this is something that Pamela Collins has been a part of, these global mental health scaling hubs. And we had a hub for Sierra Leone and Liberia called Youth Forward. And what we were testing in that particular study was having the Ministry of Youth Entrepreneurship trainers now deliver the evidence-based mental health intervention. And in the trial, we found that not only did it improve anxiety and depression in young people who got the evidence-based treatment, it also had a knock-on effect on their labor market participation. We saw that they were engaging in more successful entrepreneurship, and the effects were even stronger in young women. So I think those are just 2 examples to think about when systems are weak and the health system can't be the only solution, especially when you think of children, youth, and families. You have to move across silos, across sectors, and innovation can help us move the needle.
John.
All right, thank you, Beppy. Is that, I think it's on, yeah. Yeah, thank you, Beppy. My name's John. So I think, yeah, my response to this question, just to, well, from my perspective, is that, well, health systems have done a really bad job with mental health care. And the idea of integrating mental health care is not new. This has been, I mean, collaborative care has been around for decades. So I think, in my experience, health systems are actually more of a barrier than a solution. And that doesn't mean they're not part of the solution. And I think they are part of the solution. They create a lot of barriers. And I think you need to look at where there are successes in integrating or implementing mental health services. So in my work, I really try to focus on how do we take the interventions, the programs that we know work, and get them into the settings where people need them. That doesn't mean a health system. That actually might mean in the community, like I think as Teresa was saying. And in my experience, it's often has to be driven by motivated individuals who are in settings that are impacted by whether it's conflict or other mental health crises. And I'll speak to some of the work I'm involved with here in the United States. For the last 5 years, we've been working very hard to train non-specialists, so thinking of task-sharing models. We've worked very hard to try to engage health systems and have not had much success, actually, with the health system model. Where we've had immense success is actually working with community organizations, faith-based communities. So we're partnered with a number of churches in the San Antonio area through the Congregational Collective. They came forward with this idea. This wasn't the HMS team saying, hey, here, you guys should really use our model, let's use task sharing. They came forward, said this is a crisis in our congregations, this is cross-denomination, it's almost every sector of, every socio-demographic group in the city. They came together almost with a plea for help. I've seen the same in other settings. Our biggest success has actually been engaging organizations that are totally not even connected to the health system, whether it's veteran-serving organizations. They've also adopted these programs. So I think to really make an impact and to really move forward, we need to look outside of the health system. And I'll also just comment on the success with the global mental health, the movement for global mental health. That's been driven by individuals with lived experience. It's those who have the most invested in this and then in the success of these models. And I think that's where learning from these approaches and then how can the health system help support that, but not as the sole place to integrate mental health care.
John, can you say a little, John, about sustaining motivation and quality with community health workers? Just what's your experience?
Well, I think the sustaining motivation has to start with there being an interest in the first place. I think if you try to go somewhere where there isn't much interest in adopting mental health care or there isn't a perceived need, there'll be challenges. So you have to start, I think, understanding what is the perceived need. And oftentimes issues to do with stigma, fear, these get in the way. So I think it's really trying to understand the community that you're working with, making sure they're part of the discussions around that. That plays a huge role in sustaining motivation. If they're actual active decision makers, which is where I think some of the tension comes with the health system, is that that's often the decision makers in health systems aren't the people who are impacted the most by mental health conditions. There are other factors to do with financing and so on. Finances, of course, plays a role. But I think that's key. You have to have people who have a vested interest. They have to have a vested interest, and they have to see that this will benefit them. That's key for sustaining motivation. Then there is also the financing piece. I don't think you can avoid that. How do you find innovative ways to support it and to sustain it and to make sure that people are compensated fairly for providing mental health care?
How about you, Teresa? What's your perspective on optimizing community health worker supported care?
Really bad at this the microphone thing. Is it on? Okay. Yes, so going back to Paul and going back to the 5 S's, space, staff, stuff, systems, social support. And when we come to non-specialist community health worker delivered interventions, I think there's been a lot of train and hope, one-off trainings, burdening people who maybe don't have the training and the backstopping to take on very hard cases sometimes. And so a lot of what we've been focused on recently are strategies, testing strategies for supporting the non-specialists as they're doing evidence-based practices. And I would say our most exciting model of this has been in Rwanda, where you mentioned the family strengthening intervention. I know there are Kinyarwanda speakers here. It's called Sugira Muryango, Strengthen the Family. And this is an evidence-based home visiting intervention that was developed to promote early childhood development, but also to prevent intergenerational violence. We know there are very high rates of violence post-genocide in Rwanda within families. We want to stop those cycles of violence. We're focused on finding the families in extreme poverty by working closely with the social protection system of the country. And then we've been training non-specialist workers to do the home visiting. And there are 2 constructs that I think, especially Vikram and John, you've done a great great job in pulling out in your research. One is competence. So, is the non-specialist able to have the soft skills to facilitate, to respond appropriately, to manage the session? And the second construct is fidelity. So if there's an evidence-based practice, are they adhering to the evidence-based practice? And we in the Sugita Muryango program have had a LEGO-funded initiative that was an implementation science intentional effort to really do that quality improvement at every level of the implementation ecology. We called this the Play Collaborative. And that meant that everyone committed to quality improvement and supporting the non-specialist workers at every layer of the implementation ecology. We had a national steering committee, district steering committees, sector, and then cell. So those are groups of villages. And we're drawing techniques from, collaborative team approaches, implementation science techniques of union learning collaboratives, where everyone commits to quality improvement and cross-site learning. So as across our 3 districts, if they encounter implementation barriers in trying to do this intervention, like people are not on the national health insurance, the mutuelle, or there's malnutrition in a region, they would use a plan, do, study, act cycle to sort of analyze where those barriers are, and these are going back to evidence-based practices and implementation science. And when something works, when an innovation works, to share it out. Don't keep it just in your district, share it with the other districts so that everyone's learning from quality improvement as we go. And Laura Bond, who's now working with Vikram's team, was a doctoral student in our lab, and she looked at the home visitors' trajectories of fidelity and competence when they got this sort of quality improvement supervision, which included pop-up supervision, one-on-one sort of role play to coach home visitors to improve their practice, and we see their trajectories improve over time when you take an intentional approach. But that is that, of the 5 S's, the social support backed by the systems and the human resources strategies.
Carmen.
In Peru, we are having very huge problems with psychologists. We don't know, especially in the community interventions. And 8 years ago, for example, we include one intervention for pregnant mothers that are having depression. Bepi and another colleague, Jeron Galea, talked to small psychologists, 5 or 6 psychologists, about one intervention that provides a World Health Organization. The name is Thinking Healthy. And in this program, we need to provide 16 sessions to the pregnant mothers with depression. And in this moment, we identify a huge problem because we don't have enough psychologists, and we need to move to community health worker. And we learn about the intervention, and then we talk to the community health worker. And then it was amazing. We start with 11 mothers with depression, and now currently we are having 700 mothers that were included in this program. But the principal key in this intervention are the community health workers. They are working in the field with all the mothers. They are working in every house because in Peru we don't have clinics. Our clinic is the patient home, is the pregnant mother home. And the community health workers are going every day, every week, per 16 weeks, or 15 months to the house of the mother. And the another problem that we identified, that we need to keep a motivation and quality in their work, how Teresa was saying. And we need to continuous learning process. We have activities with the community health workers. We need to identify what is the most vulnerable situation that they are spent when they are visiting their homes. We need to identify social condition in the mothers, in the community health workers too. For this reason, we provide one program. The program is Caring for the Caregivers, because all the community health workers receive psychotherapy, individual and groupal psychotherapy, because we need to be sure that the community health workers are good, like to the mothers. And for this reason, we provide this intervention, and additionally, we provide social support for the pregnant mothers too, and for the community health workers too.
Thank you. All right, this is our last question. Looking forward, what do you see as the most urgent frontiers, conceptually or operationally, for achieving mental health for all through global collaboration and reimagining mental health care? Teresa.
Sure. So I learned a lot in my years with Paul and Jim Kim and others in global health delivery and taking that to my work on mental health. I actually went back and did some retraining and did a 2-year fellowship in implementation science at the Implementation Research Institute at Washington University in St. Louis. And I think our field has been dominated by randomized controlled trials. For a long time, we've been asking, what works in different contexts and cultures. I started in this field in 1995. In those 30 years, we've seen a lot of progress. We've seen a lot of trials. We've seen a lot of good evidence that, yes, non-specialists and others can do evidence-based mental health interventions in diverse cultures, in diverse settings, even in war-affected settings. But what we're failing to do is now shift our research questions to the questions of how do you scale with quality and sustainment. And that may mean that once we've got the evidence base, we have to start asking new questions, such as what are the best strategies for scaling? What are the most effective supervision strategies so your community health workers or your non-specialists don't burn out? How can you ensure quality improvement in a way that's rapid cycling and feeds back into system strengthening? What's the role of digital tools? Can they help the non-specialist worker? Can we use digital supported interventions better in low resource settings? And also, how do we convince policymakers? What are the best strategies for communicating return on investment arguments and budgetary allocation to mental health and workforce strategies? So I think the era that's before us is an era of scaling with quality and sustainment, and it's one where we have to shift to new research questions.
John.
Okay, well, I have to find something different to say. So you took everything out. No, those are all really good points. I agree with everything. Because we do work that's too similar. Yeah, I think we're at a really exciting time when it comes to mental health. I think the fact that the Paul Farmer Symposium this is the topic, I think is a testament to where we are as a field. I think the research it couldn't be in a better place. When we think of the research on task sharing models, so how do you train ordinary people in the delivery of mental health interventions that are proven and can do so with high quality. We know that's built on decades of pioneering research in low resource settings, work that Vikram has led and other colleagues in sub-Saharan Africa and elsewhere, and then most recently replicated in high income settings such as Canada and the United States, the work that Daisy Singler led with the Summit trial. So I think we have just an incredible amount of evidence. And I know when I go and talk to community partners, so I do a lot of work in the United States and in Texas and now increasingly in California, bringing these models because they're seeing this work, especially in faith communities, veteran communities, and I think it's really exciting. I just spent time out on the West Coast presenting with United Way, so with Linda Yu and United Way, showing the kind of this is what we're doing in Texas, and the number of community organizations that were interested. And this is in agricultural communities, rural settings. It's incredible. They see this working. So the work that we have that's moving forward in parts of Texas, that's building on work in other parts of the world, it's building momentum. And I think that's really exciting. So we're seeing this move forward. I agree completely with Teresa that we need to focus on implementation. I think it's looking at alternative models for implementation. So alternative organizations. I think it has to get out of the health system. I can't emphasize that enough. I don't think the solution will be embedded within health systems, but they have to be a key player in that model. You need to have some kind of referral network. And that's what we're trying to navigate right now with a new program in South Texas, in the McAllen area, in the Rio Grande Valley. How do we connect rural communities with a central referral network? I think the other thing, and Vikram mentioned this in his opening remarks, is moving away from a diagnosis model. I mentioned a very similar thing. I was recently presenting at the UN General Assembly. I think some people listened to it, although then every country spoke afterwards, and they seemed, it didn't really matter. They all had their remarks about what they're doing for mental health care. But I mentioned that I don't think that diagnosis and billing codes and these things have just dominated policy and practice for so long and create so many barriers. They entrench models of stigma around if you have a diagnosis, then you have this label. We know that many individuals will not seek mental health support because if they have a diagnosis, they'll lose their job. I mean, there's many people, we're thinking of law enforcement, military, first responders, even clinicians are at risk of aviation. So it goes on, the list goes on. So basically, we've created a system that no one actually wants to use because once they've used it, they're labeled. So we need to really think away from the diagnosis model and how to get into the communities. But I'm excited about it because, again, we have the evidence here, and I think we have the right momentum to move this forward.
Carmen.
Yeah, I want to share about experience during the pandemic, because in Peru we have a difficulty situation because we have a lot of people that was so terrible in mental health situation with distress, with trauma, and in Socios en Salud I believe that the interventions in mental health was only face-to-face. And in pandemic, all the situation changed. My paradigm changed. Because in this moment, we include technology in our interventions. For example, in those situations, we include chatbot because it was more easy to evaluate in the cell phones. And then the psychologists provide remotely intervention. Socios en Salud changing and changing. We interview close to 100,000 people in mental health support during 1 year. It was incredible. And we adapt some chatbots to Quechua. Quechua is an indigenous language because we move it to another intervention. We move it to difficulty situation, but new intervention was the more good options. And then we identified that it was possible to provide psychological first aid online, and we provide response quickly to all the emergency in Peru. It was not enough, but we include those interventions to the Peruvian people. And then those interventions, we move to the Minister of Health. We include those interventions, those experience to the Global Fund project. This year, we include the chatbots, we include psychological first aid, we include problem management plus to a huge population that are living with HIV, with tuberculosis, in some cases with COVID too. And those tools, it's not only with Socios en Salud, now is with the Minister of Health. And they can to include in more intervention. And in this moment, we are working in 13 regions of Peru. And I think it will be a model that we can continue in different interventions. We provide some pilots, we provide some small intervention, but then some donors, some institutions, the Ministry of Health can provide the similar intervention to more people in the countries.
Thank you. We are going to have one more question on advocacy and policy change. So perhaps the greatest challenge facing global mental health in the coming decade will be the health of young people. As was mentioned, 50% of mental disorders start by the age of 14, 75% by age 24. This in particular will demand approaches that bridge clinics and communities by emphasizing preventive as well as clinical approaches, person-centered approaches in which preferences and values of the persons receiving care and support are honored, as was also described earlier, and working towards establishment of optimal healing environments for individuals to receive care and support as close as possible to their homes and communities. Yet structural challenges, social and political unrest, human displacement due to various disasters, and ongoing lack of financial commitment to mental health services and programs impedes our ability to meet the need. What advocacy strategies have proven most effective in convincing policymakers to invest in mental health as a component of overall health equity and social justice? Teresa.
Yeah, really important question. I think as an implementation scientist, the trick here is to find the win-win. And in the work I've been involved with in Rwanda since 2006, in the early days, we had this family strengthening home visiting intervention that was for one form of adversity, which is households affected by HIV and AIDS. And I had the honor of meeting Dr. Agnes Benawaho and knowing of all the amazing things that community health workers were doing in Rwanda. Of course, we approached her and said, how about we work with the community health workers? We can train them to do this evidence-based home visiting intervention. And Agnes, rightfully so, said there's too much on their plate. We can't overburden them. That's not the strategy for scale. So we went back to the drawing board. We continued to do our research with non-specialists and all of that quality improvement and supervision to the non-specialists. And then an opportunity emerged. And this was, as Rwanda is very evidence-based, they, like many countries around the world, were moving children out of institutions into family-based care. And to do that, they needed a workforce. So Rwanda launched the Inshuti Z'umuryango. Again, I'm butchering my Kinyarwanda and I apologize. But that means the Friends of the Family Workers, or we call them the Izus. And there is one male, one female in every village in Rwanda. So talk about a potential for scale. So then we went back to the government and said, could we establish an MOU to train and facilitate the evidence-based home visiting done by this volunteer workforce, the Friends of the Family, and we got the MOU. And why it's a win-win? That mandate of the child protection volunteer is to reduce violence. Our intervention has an evidence base for reducing violence. We do gender transformative caregiving to young children. They have a gender transformative mandate in what they do. Government of Rwanda very much believes in that. And because we've now found that win-win, we have scaled that program to 20,000 families. In my career, I never thought I would achieve that. It's my team. You saw the team. That was just one district team, and there's 3. So we're moving into 5 districts, and now with a philanthropic partner, there's the potential to take the evidence-based intervention to 18 of 30, and my goal is to get to all 30, and then I'll retire.
Carmen.
Our main advocacy strategy has been to show evidence from practice, from what really happens in health centers and in the communities. In Peru, we have a gaps between mental health and physical health. And part of our work has been to demonstrate that there is no health without mental health. We have documented all the results that we are working, especially among young people, mothers, and people with chronic disease. And we have presented this evidence to the Minister of Health and local governments. This evidence, both data and personal stories, has been key to convince decision makers to invest in mental health as part of health equity. It is important to mention that we have worked hand in hand with the public health system. How I was saying, our intervention is in the health center that the Ministry of Health is having. We don't have in parallel, we have with the Minister of Health. Another key element has been given voice to the communities. We include young people, we include mothers, we include community health workers, and people living with mental health conditions. They participate in public events. They participate in our parades, in media space. And with their experience, we become the best advocates for the right to mental health.
John, thanks.
Great, yeah, thanks very much. And yeah, just thanks to my other panelists, it's great remarks. I think when you mentioned the comment about the youth mental health and advocacy, I think when we think of the youth mental health challenges, or it seems as this impending crisis, and I think it's certainly a huge issue, but I think I look at it in a more optimistic way. I think the reason we've actually made so much progress in even talking about mental health is because young people have been talking about it and forcing older generations to recognize it as an issue. I think of the situation on college campuses. This predates COVID. It wasn't that college, university, or university health services said, "Oh yeah, I think mental health is something we should be thinking about." No, it's because students were demanding it. And I think technology has helped that in a great deal. I know technology is like a double-edged sword, but it's also played an incredible role in advocacy, with young people sharing their stories, with people connecting. And I think there's an opportunity to build on this momentum. I think the engagement of people with lived experience, an incredible amount of young people are engaged now and engaged in these conversations. And I think there needs to be, basically the door needs to be open so they can be part of the research process. We need to figure out how to nurture this momentum and this interest in order to then really have some kind of meaningful impact and make sure that we can integrate the science that we have and then figure out how to do the implementation part and make sure it's done well. But I think building on that momentum that young people are actually bringing to the table.
Thank you so much. Do we have more time? Okay. I'm just going to summarize a couple things I heard. Just a couple key points. Mental health care must be integrated across conditions, across sectors of society. Community partnership and task sharing make care scalable. We have to be careful not to overstretch or commit frontline teams, and we have to take care of those teams. Advocacy drives change when it's tied to evidence, community voice, and partnership. And collaborations are needed, and they can take many forms. And then the future of global mental health, locally relevant and globally informed, is upon us. And we do have knowledge, and we do have tools that work. For those of us who are mental health professionals, we're actually all global, and we need to integrate that perspective as well. So thanks to our panelists very much.
Please join me in welcoming Dr. Louise Ivers.
Hi, everyone. I'm Louise Ivers. I'm an infectious diseases doctor at Mass General Hospital and a professor at Harvard Medical School, and I'm the director of the Harvard Global Health Institute. It's a pleasure to be here today, and I want to thank the panelists, Beppy, Carmen, Teresa, and John, for a really insightful discussion and conversation. I've had the pleasure of working with Zami La Santé in Haiti for more than 20 years now, and it's been such a privilege. For the last 3 years, Haiti has been gripped relentlessly by violence, and gangs have expanded their strongholds, now covering a population of about 3 or 4 million people. The rule of law has been cast aside, and vast amounts of progress over the last 15 years are threatened or destroyed, and millions of people have been displaced. More than 8,000 people have died in violence. And so, partly in reflecting, as you spoke during the panel, I was thinking about the fact that in addition to what is typically highly visible public health impact of this type of violence, with a cholera outbreak and a diphtheria outbreak in Haiti, as well as things like increased maternal mortality and malnutrition, a really particular concern that's rising is an increase in suicide. This has been spotlighted in the Haitian news and has been a flashpoint recently with a number of very visible and written about deaths. Earlier this week, Dr. Ralph Tournier, one of the leaders at Sami La Santé, and I were speaking, and he highlighted the rising suicidality amongst the rural poor. And Ralph said to me, you know, rural communities are typically so resilient in Haiti. They're kind of famous for being resilient, but now they're finding that there's just no hope. And so as we reflect on this important topic for today of mental health, I've really appreciated the discussions so far, and I know what's to come. And it made me reflect on all that Paul told me and taught me about both structural violence and to direct violence, and how partners in health and certainly Sami La Santé's frontline workers are really working hard to be an antidote to despair, and how despair is such an important component of poor mental health. So I'm delighted to introduce the next panel, Action in US Mental Health Advocacy and Policy, which in the face of rising mental health needs across the US, will explore how policy, public health, and advocacy can come together to drive meaningful change. It's my real pleasure to introduce the moderator of the panel, Dr. Joya Mukherjee. She is the F.W. Peabody Society Director and Advisory Dean at Harvard Medical School. She's the director of the Master's Program in Global Health Delivery at Harvard Medical School, an associate professor of medicine at Brigham and Women's Hospital, and a senior academic and clinical advisor at Partners in Health. Joya's accolades are, as Paul would say, TNTC, too numerous to count. I'd like to welcome you, Joya, to take the floor. Joya is a force for global health equity, a tremendous leader and teacher, and I'm proud to count her as a friend and a colleague. And I welcome you, Joya, to take the microphone.
Thank you so much. It's really an honor for me to moderate this panel of two real giants and thinkers in mental health, in global health, and in how we think about big ideas. In Paul's book, Pathologies of Power, he outlines the inextricable link between social conditions in which people fall ill and die, and the biomedical health. This biosocial model, or as Professor Kleinman will correct us, biopsychosocial model, must be understood through a lens of social science. Paul was so proud of our department, the Department of Global Health and Social Medicine, and the use of what he always reminded us, the important re-socializing disciplines. How do we look at medicine through a lens of political economy, through history, with tools of anthropology? And so many of these things allow us to get proximate to the pain, proximate to the suffering of people. We understand the global crisis in mental illness and the lack of care for those suffering, not only through epidemiologic and quantitative data, but through the careful study of lived experience of people facing mental illness and of those who care for them, their families, their communities. We also understand this crisis through a much larger political and economic lens, that forces that neglect the poor, that neglect the serious problem, and make invisible people suffering these catastrophes. In Paul's book, AIDS and Accusations, Haiti and the Geography of Blame, the book that he published as part of his PhD thesis that he did with Professor Kleinman, he interviews people living in the community of Dokai in Haiti. And one thing that strikes us about these interviews is that one patient living with HIV says, I do understand AIDS, but it's not the first thing. It's not the first thing in her life, because the first thing is needing to feed her family, needing a roof over her head. And we understand that mental illness is also, for many people, not the first thing. It is part of accumulation of wounds, of stresses, and it's for this reason, this exploration of pathologies of power and their impact on mental health and the barriers to care, that we have invited our two amazing panelists for the second panel. Both are really out-of-the-box thinkers whose work is both global and domestic, who understand what Dr. Farmer said, the most basic right is the right to survive. And this right is being trampled in an age of great affluence and neglect. Dr. Pamela Collins and Dr. Jim Kim will explore how policy, public health, and advocacy can come together, and indeed have come together, to drive meaningful change and inform models that can be adapted globally. Dr. Collins is the Bloomberg Centennial Professor and the chair of the Department of Mental Health and the director of the Johns Hopkins Center for Global Mental Health at the Johns Hopkins Bloomberg School of Public Health. She's a psychiatrist who I understand was also a mentee of Professor Kleinman. I just learned that today. She is a researcher who seeks to understand the intersectional vulnerabilities that underpin mental health challenges and contribute to poor outcomes. Through her research, science policy, and global public health implementation leadership, she has worked to expand access to mental health care for individuals and communities globally. She was the 2024 American Psychiatric Association's Chester Pierce Human Rights Awardee, and she chairs the APA's Council on International Psychiatry and Global Health. Prior to her tenure at Johns Hopkins, she was the director of International Training and Education Center for Health, iTech, at the University of Washington, and the Global Mental Health Program there. She has also worked for the National Institutes of Mental Health in the Office on Research on Disparities in Global Mental Health. Dr. Jim Kim is well known to this audience as he used to be the chairman of our department. Among his many accolades, he is currently the vice chairman and partner at Global Infrastructure Partners, part of BlackRock. He's the co-founder and board member of Partners in Health and our chancellor at the University of Global Health Equity in Rwanda. Dr. Kim was appointed by President Barack Obama to serve as the 12th president of the World Bank Group. He was also the president of Dartmouth College and the director of the World Health Organization's HIV/AIDS department in the important era of the early scale-up of antiretroviral therapy, the 3x5 program. His work on changing the paradigm for MDR-TB treatment and earned him the MacArthur Genius Award. He has received numerous awards, including being a Time 100 honoree, and has been recognized as one of the 25 best leaders in the world by US News and World Report. He was also my first office mate when I came to the department. So I'd like to invite Dr. Kim and Dr. Collins to join me. I'm glad you made that train, Jim. I also want to welcome the Farmer family, Dee Dee, et cetera. I know many people are online, so thank you for joining us as we again come together to honor Paul. Dr. Collins, I'd love to start with you. Your work is really rooted in understanding the burden of disease, the barriers of access to care. Maybe you can help us frame the situation of mental health in the United States. How common are the conditions? Where do we stand with respect to access to care, utilization? and really give us an overall picture of the social impact as you see it.
Thank you so much. It's a pleasure to be here. I'll talk about this a little bit later, but I remember in 1996, soon after I finished my residency program, seeing Paul at actually at Union Seminary giving a talk that was soon to be part of the book Women, Sex, and Poverty, and was riveted by his presentation, and then came to know him, and just what an amazing human being. So I want to start by saying that the United States is part of the globe, I think as Beppy ended. so that's an important to think about, and that the beauty of global health and investment in global health is that we then have the privilege of so many minds and so much creativity coming together to figure out how to solve challenges, and certainly figuring out how we meet the mental health needs of populations around the world is a global challenge, and we need those minds, we need those experiences to be shared, and we need one. If you look at the global burden of disease data, and you kind of look at a bar chart of countries and prevalence of mental health conditions around the world, we stand out. We're not one of those low-level countries. The prevalence of mental disorders in the United States is around 19%. When you look at the adult population, it gets up to about 23%. So we're talking, more than at least 1 in 5 people is living with a mental health condition typically in this country. When you go younger and consider younger adults from 18 to 25 during those very important years of transition to adulthood, the prevalence is higher. And that's true across states. That's true pretty much everywhere in this country. And I think the last NISTA data said, I think 18 to 25-year-olds have a prevalence of around 36%. Around 36% have any mental health condition at any given time. So we need this thinking. And so who gets care? So again, similarly, the NISTA data from the National Survey on Substance Use and Health from 2022, about half of people who have any kind of mental illness get care in the United States, adults. And it's slightly less for the younger adults, but still, bordering around 50%. That's better than what we see in many countries with much fewer resources, but that's still only 1 in 2 people getting care when they need it. And if we look at subgroups, subpopulations, we're of course going to see many differences. And so why are we concerned about this? I think first and foremost, we're concerned about this because these are things that cause pain. They distress people, they disrupt people's lives. For young adults, these conditions are occurring when you're getting a start in life, when you're seeking education, getting the first job, perhaps starting a family. These can be very disruptive, and of course have long-term, if they're chronic and persistent, have longer-term challenges to outcomes, as well as to health outcomes. Yeah. So let me pause there.
Yeah, no, that's really helpful. Helpful framing. Dr. Kim, you have a unique, and some would say uncanny, ability to see around corners. And since you left the World Bank, you've become a really passionate, and even while you were there at the bank, become a passionate advocate for mental health care in developed countries as well as developing ones. Maybe you can explain why you started to become interested in this area. I know some of your experiences looking at Korea and economic development really highlighted this for you.
Thank you, everybody. And I apologize, I had a 3-hour ordeal on the train, but because of the miracle of the internet, I listened to everybody's speeches. So thank you so much for your interventions. So, I'm sitting here with my mentor of, almost 40 years now, Arthur Kleinman. And I was just in Korea, where the Confucian Society of Korea asked me to give a talk. And it was a lot of it was focused on mental health. But there's a saying in Korea, and I really feel this right now, that if you're talking about something that you're not an expert in, it's like, oh, you're trying to teach Chinese characters to Confucius, right? And so I feel that's what I'm doing. In fact, the only skill I have left is scheming and plotting.
And you're very good at it.
And apparently, you know, that's helpful at times. I was, the very first book in anthropology that I really devoured there were papers and books, were Arthur Kleinman's works. When I was a senior in college, and I wrote my thesis on culturally appropriate care for mental health disorders. So I started from an early point, caring a lot about mental health. And then when I came to Harvard Medical School to study, Arthur had just arrived. So it was like, for me, it was amazing. Oh my God, my hero is here. And so, with Arthur and, Dr. Collins, I'm sure you know about the great Leon Eisenberg, who was the first to really bring biology into to mental health. He was another one of my mentors that I started working with in 1982, along with Dr. Kleinman. So I have a deep sort of, I would say, familial grounding in issues around mental health. But we got so caught up in just trying to provide basic care, care for MDR-TB, care for HIV, but also just continuously trying to broaden our boundaries. And every time that they said, well, okay, so fine, okay, HIV care is one thing, but cancer care, forget it. We'd cross that line. But you can't think you're going to do really complex surgeries in developing countries, and we cross that line. And I feel like now we're on the line, and Beppe has certainly, created a tremendous momentum where that's really the next step. And I would argue that in many of the programs that our mental health team has started, the continuity of care is better than most patients get in the United States. Right? The whole idea of applying really simple ideas like the value chain, I think it's revolutionary. But I've gotten to know Tom Insel, who has changed his views on a lot of things, as reported by Arthur. Arthur and Tom had a debate once. Tom was the head of the National Institute of Mental Health, about whether social factors are important in mental health. Is that right, Arthur? Something like that. But then when he stepped down from his role, Tom basically said, oh my God, I missed it. That the social determinants of mental health outcomes are so powerful. And he, very much like Dr. Collins, was saying, there are so many mental health visits, and yet the outcomes aren't getting better. Right? And so my thought was that, first and foremost, we care about, our notion of a preferential option for the poor, getting care to the poorest people. But the lack of access to care is really everywhere. Right? And so, in my 3 years at Dartmouth and the 10 years before that, there were 0 suicides. A couple of years ago, there were 8. Right? And then I started studying about suicide and how it can almost become like an infectious disease. People see an example, and I realized that the conversation on campuses, and I think John had talked about how the students were insisting on getting access to care. Young people are much more open to talking about mental health. But I've been trying to think, are there things that I would have done or could have done when I was at Dartmouth that could have changed the picture, right? And so, I started learning about psychological first aid, and, Vikram's colleague, Shekhar Saxena, and the people at WHO created these wonderful tools that are just kind of like teaching a different way to look at each other, right? And so if you're asking yourself when you see somebody, could this person be in trouble? And, if you were trained in how to ask questions in a certain way, listen, don't say the things that will destroy your credibility by saying, oh, it's going to be all right. Things that I didn't know, just, off the top of my head. I thought, what if we had taught the entire Dartmouth campus, psychological first aid. I think it wouldn't, I hope it would have reduced the number of suicides, but I think it could change the way people look at each other, right? And if it became like CPR, like kind of a cool thing to learn, because you're looking at people and asking yourself not, you know, what's this person about? You know, can I date this person? Whatever it is that you normally think about, young people, you think, could this person be in trouble, right? And so it just struck me that there are so many tools now. I mean, cognitive behavioral therapy, dialectical behavioral therapy, there's so many tools that we should be training everybody in, our tasks are just starting. And it's just as relevant and urgent in the United States as it is in other countries. Now, you know, we still see people who are chained to their beds in developing countries. We've got to get out of the dark ages in mental health in many other ways. But it's not, mental health is the place where I've had to rethink my rather simplistic notion of poverty alleviation. Of course, poverty alleviation is the goal of the World Bank. It's been the goal of all of us. Poverty is not a good thing. We never celebrated the poverty of others. We fought against the poverty of others.
We don't believe poor people are happy, right?
On the other hand, in a country like Korea that went from a situation of great poverty, right? When I was born in Korea in 1959, the GDP per capita was less than Senegal, Ghana, and Somalia, right? So it went from a very poor country to being now a wealthy country. And where has it taken them? Highest suicide rate in OECD, 29 now, probably 30 this year per 100,000, which is, you know, I think the average in OECD is like 15 or something like that. It's almost double. The lowest birth rate ever recorded in human history for a nation state. You know, 2.1 children on average per woman is what you need to replace the population. In 2023, it was 0.72. So it was about a third what's correct. So the Koreans, you know, if you believe Emil Durkheim, there is a loss of social connectivity that's literally having sort of implications for the very survival of a country, right? So anyway, I'm mixing a lot of different ideas, but what I learned was mental health is a huge problem everywhere. There are many new tools. There are, of course, pharmacological interventions that are very, very helpful, but there are also just things that you can teach a broad range of people, right? And having now been in this world, I'll end with just a story. I met a guy named Kevin Hines, and if you haven't seen his story, Kevin Hines was one of 4 people that ever jumped off the Golden Gate Bridge, and both survived and didn't have devastating injuries, right? So there's like 4 people. And what he tells, the story he tells all the time is that he was walking back and forth across a part of the Golden Gate Bridge for 45 minutes, and not a single person asked him, "Hey, are you okay?" And he says that if a single person had asked him, he wouldn't have jumped, right? And he's now part of lots of groups of survivors of suicide, and he says just about everyone has the same story. And he said that as soon as his hand left the rail, he thought, "Oh my God, I know all the solutions to my stupid problem. I understand exactly what I would need to do," and then he was already falling. And a lot of other people have that experience. So I think there is there's space and tools now for a movement like we had with HIV, right? It's harder, it's in some ways more like MDR-TV, it's more chronic. The results are not as miraculous as you get with antiretroviral agents. But I think it's time for a movement type of thing to get going. And if young people start thinking it's cool to know how to deal with somebody who's in trouble, that would be transforming.
So that's a great point. I mean, I think trying to think about, and we'll come back to the idea of a movement. I think the audience would love to hear, I think, from both of you about how not only the tools for mental health, but the tools of social science, qualitative work, history, ethnography, et cetera, help us understand mental health. And Dr. Collins, I'd love you to talk about your work. I was fascinated by your work with Arctic people, and particularly around the intersectionality that you study between forces of racism, poverty, mental health, even HIV risk, and touch on some of the things that, what are we missing? Who are we missing? And how people really are left out of services.
Great. So I'll tell two different stories, two separate stories, but I'll start by answering your question. I had the privilege of being involved with work during the United States chairmanship of the Arctic Council in 2015, from 2015 to 2017, when I was director of the Office for Research on Disparities in Global Mental Health at NIMH. And if you don't know what the Arctic Council is, it's an intergovernmental body of the 8 Arctic states in the world, and the United States is one of the 8 Arctic states. And this group, for years, has addresses socioeconomic issues, environmental issues across the Arctic, but there's always a health stream. And for some time, the concerns about suicide prevention in Arctic indigenous peoples in particular has been a fairly consistent stream. And we began the work of the chairmanship after the Canadian chairmanship. And in their work, part of what they had done was to really do a scoping review of what works, right? What are the interventions that have been implemented? What do we have evidence for? What do people think works? And what they found was that there was actually pretty limited evidence base on suicide prevention interventions at that time, but there was a lot of community knowledge around what people thought was most important in those communities. And importantly, a little bit of the backstory is that when you look at the very high rates of suicide among many Arctic indigenous peoples, this is a recent phenomenon, right? I mean, many of us, perhaps it's been a phenomenon throughout our lifetime, but it's a recent phenomenon that's really began with colonization. And those political experiences of displacement, lack of self-determination, removal from land, and therefore separation from cultural heritage and cultural practices, all of those contributed to the kinds of despair, the kinds of and material problems too, right? Loss of employment, loss of income, poverty, and the many determinants that can, of course, increase risk for suicide. So that's the work that that's the environment in which we were talking with colleagues many of whom were indigenous suicide prevention researchers as well, and trying to figure out what's the next step in this work. And so we decided that we would try to do something that researchers would do, which is to say, well, how do we better measure these things, right? How can we actually talk to many of these communities to figure out, well, what other outcomes need to happen in communities to reduce suicides? What are those other determinants? What are those other social determinants that we need to address to reduce suicide? So we did a priority setting exercise to identify what some of the important outcomes are for suicide prevention. And essentially, people said, a lot of this was what you might expect. First of all, we need to be reconnected to community, reconnection to cultural traditions, and that was particularly important intergenerationally, right? Because I think one of the phenomena about suicides in the Arctic region and indigenous groups is that they're among young people, right? These tend to be quite young people. So how do we reconnect young people to culture, to identity, but also how do we get mental health services, right? Yeah. We actually need mental health care. We need quality mental health care. And one of the observations in those couple of years of going and meeting with people in different Arctic states is that there is a huge difference in resources in the Arctic in Scandinavian countries compared to North American countries and Russia. And you can see the difference in suicide rates. I mean, the disparities here and in Canada are much, much higher than disparities in countries like Sweden and Denmark, or Sweden and Norway, where you have many more resources in a healthcare system that, despite perhaps shortcomings for some populations, is still better than other settings. But anyway, that example of high rates of suicide very closely linked to social determinants, to political determinants, and the solutions that we're seeing now, interventions that are in place, are saying how do we make these links stronger? How do we link young people to communities? How do communities come together to address suicide?
Yeah, I have a quick follow-up, and I know you're a fantastic researcher, and I'm not, so maybe this is not possible to answer. But in that research, were you able, I'm curious about the Scandinavian countries, were you able to parse out at all what contribution having healthcare versus having more of a social safety net, or was it impossible to separate those out?
Yeah, that's a wonderful question, and our project was not part of the scope of what we were doing in this particular initiative. But I would say when you look at the incidence of suicide in these different countries, it's clear that there's a noticeable difference between the countries that do have more available health care than those that don't.
Yeah, and probably also that goes together with a package of a social safety net. And how does that compare, just back to your work looking at vulnerable young people in Kenya? Like, I know you looked at some, mental health services, HIV in Kenya. How does that compare in terms of vulnerabilities?
So we do work in Kenya among adolescents living with HIV, and many of the vulnerabilities in that setting have to do with exposure to trauma, exposure to violence, poverty as well, loss, bereavement. Many young people have lost parents or other guardians. So there are another set of traumatic experiences that many young people have had. And in that environment, we have been doing what many of our colleagues have been doing, is saying, how do we actually identify providers who can help extend access to care? And in that particular example, we are working within HIV care. So within the resource that's available in these communities, to say, well, how can we give HIV care providers, whoever they might be, whether they're a peer, whether they're an adherence counselor, you might be a clinical officer. Let's train you to deliver a psychosocial intervention in routine HIV care. And let's see, we're in the middle of a trial working with 30 clinics right now in 3 counties and testing the implementation of this kind of a brief psychological intervention for HIV care.
Fantastic.
But I would like to say something about a population. When we talk about who's missing, I think one of the populations that is often missing in our conversations is people with serious mental illness, people with severe mental illness. And my early work, my career really started with thinking about women with severe mental illness and HIV risk. And I learned a few things. One of them is that when you start to talk to people about HIV prevention, you're talking about very deep and personal interactions, right? You're talking about things that have to do with the private part of life, right?
And trust.
And trust, exactly. And that in asking the question, who's missing or what's missing, I was reflecting on this a couple of months ago, that I consider myself a cultural psychiatrist, and when I think about that, I think what we do in cultural psychiatry is we build bridges between care and community, right? We want to make people should feel welcome into spaces of care. And I think the many kinds of innovations that are happening in other parts of the world help do that. The care is more socially valid, the care is more accessible, you build that bridge. What I learned when I was reflecting on how we have dealt with people, and I'll talk about women in particular with serious mental illness, is that we provide clinical services, but we don't actually provide a holistic care, right? When I began to talk to women about HIV risk and how they navigated living with the mental health condition and relationships, this is not a conversation that they typically had with psychiatrists, right? This is not, and this conversation tended to happen in very medicalized ways, right? Oh, is this person's mania? Because they're having all these relationships, so what do we need to do? As opposed to understanding that this woman values personal relationships and in fact struggles with how do I hide my symptoms? How do I hide my medication? How do I do things that can sustain my relationships? And in some cases, maybe I'll take some risks because I value this relationship. And so I think that's a part of when we think about who's missing or what's missing. Are we talking and thinking about people with mental illnesses holistically? Are we thinking about the depths of people's humanity, which certainly having intimate relationships is a part of that. It's a part of being human. So,
such a great point.
Unfortunately, you know, in those early days before we had pre-exposure prophylaxis, our preventive interventions were behavioral interventions, which were effective for the most part, but very few of those have been scaled up across mental health systems when we know, in fact, that in the United States, this group, this population of people living with severe mental illnesses has at least a 5 times higher prevalence of HIV than the general population.
Wow, I didn't know that.
Yeah,
Wow.
that's the case today.
Wow.
And yet, the last study about any of these intervention trials was in 2012. And there was a recent study from New York looking at community mental health services and are people providing pre-exposure prophylaxis in those settings. And the caseloads have gone down. The HIV has not changed, but the number of people who are actually delivering these, making these services available is quite low. And the number of psychiatrists who know how to prescribe PrEP or do prescribe PrEP is quite low. I think people would like to know, I think people, but it's not really happening. So there's a gap.
Yeah.
This is a group of people that we're actually leaving behind.
And
Jim,
now that PrEP is so much better.
Yeah.
Everyone with SMI should be offered,
Exactly.
the 6-month injectable
that doesn't happen.
PrEP,
Yeah.
right? Joy would
Yeah,
know.
I mean, Jim, I was going to ask you, so, we're all sort of experienced in the HIV pandemic and the great activism that we saw from people living with HIV. What did you learn? You were pushed a lot by activists when you were at WHO, and and when I think of any intervention we want to do, we go back to those same people because they're such great activists. How do you think about taking on this challenge of global mental health from that lens of what we've learned from activists and how we continue to learn from them?
Well, thinking back to the activism, I'm trying to do some writing about it right now. The thing that's surprising is just how vehement and angry the people who were against treatment were, right? And there were a lot of people right on this campus who were just angry at us, right?
Yes.
And it was not like, well, it'd be great if we could treat HIV, but it's just so complicated. It's not what we were hearing,
No,
right?
they're mad.
They were saying, who the hell do you think you are?
Yeah.
What are you accusing us of? If it were possible, we would have done it. That's what they were saying, right? And it was 99.999% of all, frankly, infectious disease physicians, except the ones who just spent all their time in the hospital and were not involved in public health. They were saying, most of them were saying, I don't know how to treat HIV in Haiti, but if you guys tell me it's possible, yeah, why not? It's good. It's a good idea. But the anger that we went up against was, it's just stunning today because frankly, all of them are saying, oh yeah, we were always in support of HIV treatment in developing countries, and they weren't. And luckily, Tony Fauci was a strong supporter. And he said exactly that. He said, I don't know how to treat HIV in Haiti, but I trust you guys. If you tell me that it's possible, we should try to expand treatment. And so there was a moral switch that had to be, turned. And the guy who turned that moral switch was George Bush, right? And he's, to this day, revered throughout Africa as a savior type figure because of what he decided that was so out of his character, right? And not his character. I'm not saying that's completely the wrong thing. It was so out of what we expected.
Yeah,
right?
His politics at the time. Yeah.
But he did it, and not only did he do it, but he mentioned a price for antiretroviral drugs that was only compulsory licensing, MSF, generic prices, which completely freaked out the research-based pharmaceutical industry. But that one moral switch, unfortunately, we're learning this lesson in a lot of different ways, that if the President of the United States decides they want to do something, it's very hard not to go in that direction. But Joya, you'll remember, even after he declared PEPFAR, even after we started the 3x5 movement, there was still enormous resistance to doing it, right? And there were all kinds of, people were saying, well, you're taking food out of the mouths of children, and you're giving up on... Not treating
diarrhea.
Yeah, you're giving up on prevention too early. Well, I mean, we were even saying in those early days, well, if your viral load is zero and unmeasurable, doesn't that mean that you're not infecting other people, right? And but the reason I bring that up, right, is because we were trying to do something that the conventional wisdom was just totally against, right? I don't think people are against treating people with mental illness. I don't think they are, right? But just take a look at the situation in Korea. And the reason I look at the situation in Korea is that it's happening right in front of us in so many other places. Japan's already gone through this. They've recovered a bit. In 2023, Japan, which has had a notoriously low birth rate, their birth rate was almost double Korea's, 1.3, and Korea was 0.72. So they're recovering a bit, right? But they've already faced the prospect of losing about 40 to 45% of their population. They're trying to face up to that right now, right? So there's not a real resistance to taking action, but there's also not a real push to bring about a movement, right? Because the birth rate in Korea is about repairing relationships, between human beings. It's really that's what really it's about. Korea last year was the only country that I think ever in history sold more pet strollers than baby strollers, right? So there's something that fundamentally broke in that culture. Arthur and I have talked about this. In a Confucian culture where relationships are so important, how is it possible that 43% of all Koreans over 65 are living under the poverty line? The number of people in single-family households in Korea when I was born was 0.6% in single-person households. Excuse me. Last year was 43%. So 43% of Koreans living in single-person households.
Alone.
Yeah. The suicide rate among people over 65 is higher in Korea today than it was in the Nazi concentration camps among the elderly, right? So it's such a horrific example, right? And when I bring this up, people say, well, it must be this, it must be education. There's no easy answer to this. And so just like Dr. Collins was saying, I think you start off with the basics, though. So if you ask the question, to what extent are mental health services emphasized in Korea or supported in Korea? Well, the average expenditure on mental health for a health budget in OECD is about 5%. Korea is about 1%. Right? So just basically, they need more people. The sexism and the sort of hierarchicalism in Korea is such that psychologists, PhD psychologists who are highly trained, are not allowed to call what they do treatment. There's a word for it in Korean, 치료. And instead, they have to call what they do consultation. Right? And this is enforced upon them by psychiatrists, right? So it's just idiotic, right? Not nearly enough psychiatrists, and you know why? Because every single, well, not every single, but most Korean medical graduates want to go into the one field that they know is going to be have an unending demand and is going to give them the highest salary, and that's plastic surgery. Right?
Ouch.
So Korea has the highest percentage of physicians going into plastic surgery of any country in the world, right? So there's just all of this stuff piled on top of each other. And on the one hand, it is sort of the goal of every developing country. We want to be like Korea. Oh, really? Right? Wow. The women are part of a movement called the Four No's. Many of the women, right? It's no dating, no sex, no marriage, no children, right? And part of it is that it's just a kind of natural reaction to the extraordinary sexism that still exists in Korean society, but it's leading to this kind of outcome. So I think, on the one hand, just get the treatment out. So Korea has the highest suspected level of depression in OECD. 28% of the population is thought to suffer from depression, but only 2% get access to any kind of medical therapy for depression. That's what's, again, lowest. Elderly poverty is something they should be able to fix with better pensions, et cetera. Again, this should be fixable. But this other part of sort of healing relationships between people, it strikes me that teaching people psychological first aid or mental health first aid, teaching people psychological first aid is like the opposite of the sort of bullying and comparison culture that's online. It's trying to move directly against that. So you have to have, I think, both straightforward, just service interventions. I think you have to have other kind of social interventions to tackle some of the issues. You have to look at culture and language. So the euphemism that Koreans use in talking about suicide is 극단적 선택, which is just severe choice, the most severe choice. But the people I work with are trying to say, stop saying that, right?
It's a choice.
Because it's like the notion of committing suicide is that you're doing this because you really want to, right? Yeah. And for most cases, again, Dr. Collins is the expert, but suicides are preventable, right? And especially among the young people. So it's get the services out, do things like psychological first aid training, but then at some point, the Koreans are going to have to talk to each other and say, what happened here? Anomie is one of the forms of suicide that Durkheim talked about. That's just individuals who feel completely detached from society, right? And there's so much of that in this country that K-pop, whatever, Demon Hunters, it's like, oh my God, they're doing so well, right? But in the midst of that quote unquote doing well, the fundamental structure of that society is crumbling. I hope Arthur talks a little bit about some of these issues, but this is coming for everybody. It's coming for China, right? Yeah. It's already going on in Japan. Yeah. It's happening in European countries.
Thailand, I heard.
Thailand. This is coming for everybody. Yeah. And it is at first, we have to deal with mental health issues first, but then the kind of arts of community, the art of relatedness, we're losing that, and of course, social media drives that.
Dr. Collins, it makes me reflect on that fascinating anecdote you're telling me about women with severe mental illness and their need for connection. How do you think about the caregiving? It's not just taking care of mental health, but how are you taking care of the whole person?
What's interesting was that in that work, one of the things that we found was that some people had a very deep connection to their clinic, right? Because they spent a lot of time there. They might have gone to day programs. And in those places where people felt like, I go there, I learn something, I'm able to integrate that. In fact, that makes me, someone described that as changing their identity. Like they were not crazy.
Wow.
They were people who had a mental illness,
Yeah.
and they knew what to do. They knew how to get it taken care of because they had a wonderful place of care that was caring.
Yeah.
Right?
Yeah.
And that they felt a connection to. So I think
Yeah.
how we create those for people who have more serious illnesses is very important. And then how we do that in the community, right?
Yeah.
I mean, I feel like this is perhaps where many of the countries that many of us work in, where community is so important, right? And people actually, community is such a strength. You know, how do we export that, right? How do we reintroduce that to places where community is being replaced by screens as opposed to people? So what's the, you know,
It has to be different and new, right?
Yeah.
That, you know, older men were always so comfortable in Korean society because, you know, everything went up to them, right? It was comfortable for them, but it wasn't comfortable for everyone else, right? So it wasn't comfortable for people younger than them. I mean, in Korea still, you don't have a voice in your company really until in your 40s and 50s, right? So there's, and the way I would see it is that it's not really because of a Confucian ideology, right? It's individuals utilizing the concepts from Confucianism to make their own lives better.
Justify
right?
power.
Justify
Yeah.
power, justify, and also the older men, you know, who are now running the place, you know, they took all that crap for all their lives when they were young, and it's like, now is the time, right? But women still, you know, the leadership of companies are just still so much male dominated, and so you know, the hard thing for Korea is going to be, you know, many of them said, well, you know, back in the day when we, you know, it was much better. Well, back in the day, it was not so great for women, and so unfortunately, it's not about going back there. It's about going even further, you know, with you know, with you know, the sort of growth of feminism in that society. It's going to be hard, but again, this is every society is going to have to deal with this.
And I mean, I think to me, the takeaways from, you know, what both of you are saying is that the services are needed, but that the care of the individual, the building community, the recognition of how people become detached, deracinated, is as important, if not more so. And so as we think about the crisis we're facing in the US, and Jim, I remember my very first year that we shared an office talking about the book Bowling Alone, and the sort of fragmentation of the safety, you know, the social network in the United States, and that was before really even Facebook, I think. So I want to thank both of you. I know we're going to hear a lot more from Professor Kleinman, but you know, this global mental health, as Dr. Collins started us off by saying, the U.S. is on the globe, and maybe some of these great lessons we heard from other places in the world, we can build a better social contract and provide access to care. Thanks.
Thank you.
We will now pause for a 15-minute break. Please take your seats as the symposium will recommence in 2 minutes. Welcome back. Everyone, please take your seats. Welcome back. And now a video from John Green, New York Times bestselling author, vlogbrother, and PIH trustee.
Hello, I really wish that I were there at the symposium with you in person, not least because mental health is such an important issue in my particular life. I've lived with serious mental illness for most of my life, and I am alive today because of the kind of support and treatment that everyone deserves, but unfortunately very few can access. Of course, one needn't look far to see inequities in the mental health care system. Here in the US, the psychiatric care system can be extremely difficult to navigate and prohibitively expensive, but in impoverished countries, the gaps are stark. Uncounted millions live with serious mental health challenges and little or no access to care. Like a Partners in Health doctor once showed me what he called the largest psychiatric pharmacy in Liberia. It was perhaps 2 feet wide and 2 feet tall. This inequitable access to care is precisely the kind of injustice Paul Farmer spent his life trying to rectify, and I'm so glad that this symposium is tackling this important issue today. Thank you.
Good afternoon and welcome back. It's an honor for me to introduce a person who really doesn't need any introduction, surely, in this community. But nevertheless, I need to introduce him formally in my role. Arthur Kleinman has served Harvard University for 50 years. 50 years. And he has been a faculty in our department since 1982. Arthur has many unique distinctions in his service to Harvard. He's not only chaired a department in the medical school, but he's also chaired a department in the Faculty of Arts and Sciences, and he has also been the director of the university's Asia Center. His singular scholarship has been the foundation of many disciplines of scholarship. I can count amongst them medical anthropology, cross-cultural psychiatry, and both of these are in themselves foundational disciplines for the field of global mental health that so many of us, including myself, consider our home discipline. Indeed, as I embarked on my first steps into global mental health after finished psychiatric training in London back in 1992, I was going to Zimbabwe for 2 years, and I had only enough space to pack what I could in one suitcase for those 2 years. I could think of only one book that I could squeeze into my suitcase. And it didn't take me long to really decide which book I put in my suitcase. It was Patients and Healers in the Context of Culture. And Arthur, you will remember, I had the honor of getting that dog-eared copy, the original copy signed by you a few years ago. His remarkable journey of scholarship originates from the 1960s with his field research in Taiwan and then extending to mental health problems primarily in Southeast Asia and East Asia, especially in Japan, but also in East Africa. Along the way, he founded the seminal journal Culture, Medicine, and Psychiatry in order to advance scholarship in what we now call global mental health at the intersection of anthropology, the clinical mental health sciences, and the rest of medicine. He led the departmental teams that produced the first World Mental Health Report, which I consider actually the very first landmark publication in the field of global mental health, which was released in the United Nations in 1995. And he also led the team that produced the Out of Shadows report at a time when Jim Kim was the president at the World Bank, and that was released in 2016. But perhaps just as relevant to the keynote that he will give in a few moments was his unique relationship with Paul, which, of course, I'm sure he will refer to generously in his remarks. This relationship goes back to Paul's earliest days in the academy during his undergraduate days in Duke. And in fact, it was Arthur who recruited Paul to our department. And as they say, the rest is history. From a personal perspective, Arthur, you were the friend and mentor that I needed when I first arrived in this country in 2008. I still remember very well, you had told me to watch my step. You had said, Harvard is like a minefield. But you, through the sheer dint of 50 years of service, knew where every mine was, and you would help me dodge them. I thank you for shining a light. Friends, please join me in giving a warm welcome to Arthur Kleinman.
Thank you. Let me first thank the organizers and the various wonderful units that support this annual symposium, PIH, the Department of Global Health and Social Medicine, the Division of Global Health Equity, etc. I want to begin by acknowledging and affirming Paul. And I want to read something to you that I think represents what Paul would say in the bad time we're in if he stood before us right now. This was written by a great figure at Harvard who died in 1910. His name was William James. William James wrote, "The solid meaning of life is always the same eternal thing. The marriage, namely, of some unhabitual ideal, however special, with some fidelity, courage, and endurance, with some man or woman's pains." And it's the pains that we all are feeling and going beyond with fidelity, courage, and our, hopefully, longer-term endurance that will not only carry us through this difficult period, which I regard as fundamentally anti-care, and I'm going to talk about care today, and onto a future that is a brighter and better future. Paul, if you were here, I'm sure you would have said something a little more off the cuff than that, but having the same effect. Now, it's good to remember that Paul's original interest was actually in mental health. It was in cultural psychoanalysis. And Paul, who was studying at Duke with some wonderful anthropologists, Weston LaBarre and others, was in Paris when he wrote to me in 1981. I was at the University of Washington, having left Harvard for my 10-year job, was at the University of Washington in psychiatry and anthropology. And Paul basically wrote and said, "I want to come and work with you." And his work then was with a great French ethno-psychiatrist who was desperately ill, George Devereux. And had Devereux not been ill, it's quite possible that Paul's career would have entirely been in the mental health field, not in infectious disease. What attracted him to Devereux and to the field was the intersection of culture and the individual, of society and the person as an embodied set of values and emotions. So at the very start of things, he was aware of why mental health was important. And this was the letter Paul wrote me. It now sits in the Countway Library in the Paul Farmer file. Paul came of age in infectious diseases at a time that 2 generations before him, and even the generation before him, there was not only suspicion, but active hostility among the leaders of what was called then international health toward mental health. And a good example is that I was always introduced at international health settings by the leaders of global health or international health at that time, almost all of whom were infectious disease doctors, as an anthropologist, never as a psychiatrist, okay? It was almost a stigma for them to use the word psychiatry. And in turn, mental health problems were not seen as significant problems. And that actually carried over into public health more generally. So the fact that someone like a great leader today, like Pamela Collins, is the head of a department in a major public health department, maybe the public health school, maybe the major public health school when it comes to the international domain, is amazing. Is an amazing change over time. Mental health arrived as an important aspect of public health with the global burden of disease. And having taught Chris Murray when he was a medical student at Harvard, I don't think it was Chris's intention to have done that. It just were the findings that made it clear how important mental health problems were. One of the consequences of the arrival of mental health as significant was not only the attention to things you heard so well presented in the previous panels, but a concern for care. A concern for care, because in the mental health field, care for a very long time has been a central interest. And we can actually say that this was one of the fundamental contributions of psychotherapy and counseling, not only in our country, but around the world. Now, you'll see this is a blank slide, and that's because owing to the principles of PIH, they have asked me to remove pictures of mentally ill in cages, stigmatized in horrible ways. But just think about it and imagine it. So I had a picture here of someone from my own research in Taiwan in the 1960s who was in a cage about the size of this podium, just a little bit bigger, and had been caged for 20 years. Okay. I remember when I went to Ranchi in India to visit the asylum for the mentally ill there, I spoke to a number of patients who told me just how badly they had been treated because of their psychosis. For our own society, you don't even need numbers, that we could give you the numbers. In our society, the de facto mental health system is the streets and the prisons, because so substantially unchanged is the stigma around chronic mental illness that our system has failed entirely, not just the health system, but our social system, to care for the mentally ill. And so I don't want us to lose in our focus on well-being, which is very important, the significance of stigma and social death. And this occurred to me when I first went to China in 1978. I went to China in 1978 as part of a very high-level government-to-government group that included Bill Foege, who then was head of the CDC, the head of the hospitals for the US at the HHS, many other figures. And when we arrived in Beijing, the Minister of Health, who traveled with us, said, "Arthur, you know, I'm going to be very sad for you, because being a communist country, we don't have mental illness. So you as a psychiatrist are going to find that you'll just have to pay attention to other things." And the first village we came to, because I was Chinese speaking, I saw a man, an older man, with kids throwing stones at him. And so I went up to the kids and spoke to the kids, and I spoke to the man. And he was mentally ill, had a serious psychosis, had just gotten out of a hospital. And he was socially dead. That's why they were throwing stones at him, because, as the kids told me, he's not a human being. Okay. Now, that has improved in many societies around the world, but not all that much. Stigma for depression, anxiety has improved enormously everywhere, but not for chronic mental illness. And it's very important when we speak about the mental health field, as Pamela Collins reminded us, never to forget chronic mental illness. So one of the great things that has happened over time has been global mental health champions. And of these, my good friend, Kay Redfield Jamison, is a very, very good example. Kay, who's a brilliant psychologist in psychiatry at Johns Hopkins, is a world expert on bipolar disease and also suffers from bipolar disease. And she's written what I believe for Americans and English speakers is the single best book on the experience of psychosis, which is called An Unquiet Mind. I don't have to tell you about Lady Gaga, Stephen Fry, because they've been so public about their mental health problems, but I just want to mention Tom Osborne. So Tom was an Eliot House Harvard undergraduate who was a little bit older. He's a Luo from Kenya, who had built in the Kibera slum in Nairobi a community health program, and he was majoring in psychology, and did his research with John Weiss in the psychology department at Harvard. And John, Tom and I wrote a set of articles together. He's a great champion, a good example of a champion in Africa of mental health. Now, the fields that you heard about, medical anthropology, cross-cultural psychiatry, have contributed very importantly to global health. And here are some pictures of outstanding figures in those fields. Tanya Luhrmann, professor of anthropology and psychology at Stanford, who's done brilliant work on the universal presence of hearing voices and the way it's distinguished in different societies and taken care of. That's Angela Garcia, who's the chair of anthropology at Stanford, and one of our former students, who has written some of the most powerful accounts of substance abuse and the way that people in the Southwest of the United States and also in Mexico have struggled in dealing with generational substance abuse. I don't have to talk about my colleague Byron Good, who for a long time has contributed so importantly to this field. Janice Jenkins, who I regard as probably the most important anthropologist working on chronic mental illness and also on the mental health problems of immigration today at UCSD, another one of our former trainees, and Roberto Luis Fernandez, professor of psychiatry at Columbia University, and another graduate of the long-time program we had here at Harvard in mental health postdoctoral and predoctoral training, of which he and I think, I'm trying to remember, Pam, if when you came, that you were supported by that program. I'm not sure as well, but Pamela at least participated in what that program was about. So here I want to talk about the thing that Paul has emphasized in his career, that he and I have taught about, and that I've tried to carry forward in my own work. And that's the importance of care and caregiving. We're all familiar with Paul's idea of accompaniment, but actually accompaniment is a provocation. It's a provocation. Because if you read Paul's understanding of accompaniment, it isn't just accompanying a patient for a short time. It's accompanying them for a long time. It's accompanying them in context and in terms of the way that their illness affects their lives, affects their families, and how the social world has contributed to that problem. Acknowledgement and affirmation are the first acts of care, practical assistance, and the real work of caring that happens in families: feeding, bathing, ambulating, toileting, protecting. Emotional support, such an easy term to say, such a difficult thing to do. Moral solidarity and responsibility through presence, through being there. I really want to emphasize presence because I think that's what Paul meant by accompaniment, and that's what he himself brought. Presence, that fullness of being, that engagement, that commitment, not just going through the motions, but being there, being there. Crucial in the mental health field, crucial across all of healthcare. And the rest, I think, we know about, and I just want to emphasize the importance of enduring. Enduring. That I took care of my late wife, Joan, for 10 years, and because she died of early onset Alzheimer's disease. For those 10 years, it was learning how to endure that pulled me through. And that's what many people dealing with all kinds of chronic illnesses are about, enduring. How do we learn to endure? And by enduring here, I mean with joy, with happiness, but also being able to handle tragedy, sadness, and defeat. Rituals and habits get you through that. Well, you've already heard about from our panels about global mental health, but I want to point out that you can see a kind of generational progression here. Starting with Leon Eisenberg and Julie Richmond in our Department of Global Health and Social Medicine, which before Jim was called Social Medicine. And Jim changed the name, and I think rightly so, to Global Health and Social Medicine. But coming down to, from Leon to me, actually this can be seen through the name of a chair. Leon's chair was the Presley Professorship in Social Medicine. That came to me. I was the Presley Professor. I passed it on to Ann Becker, who regrettably can't be here with us today, but is the Dean for Clinical and Academic Affairs at Harvard Medical School, and an important figure in global mental health, particularly around eating disorders. Vikram, you took for granted that he was going to be the chairing this, and and speaking as introducing people. Vikram is the single most important person, in my view, in the global mental health field. And his presence solidifies how important that is in our department. Bepi represents the actual work of mental health out in the world, doing things in the world, getting things done just like we would want them done for infectious diseases, for heart disease, for cancer, getting them done for mental health problems, including serious mental illness. Now, there's a contradiction I want to draw our attention to. And this is true of all of global health, not just mental health. Many students and professionals are attracted to global health because of a passionate interest in care and caregiving. I can tell you this is the case because after I wrote The Soul of Care, I've been invited to half of America's medical schools, half of them, okay? Fortunately, I haven't accepted all those invitations, okay? But in contradiction to that desire, that enthusiasm, the quality of caregiving is not a major focus of global health policy and research, which, to be fair, largely focus on the question of access. No access, no care. But access to what, we can say? What does it mean for global health that the existential and moral stimulus for entering the field has become such a small part of what the concerns of the field are in practice? And what does it mean when we don't ask access to what? Okay? And I want to suggest it's access around the world, including in our society, very much to poor care, poor quality care. Concerns in this regard are the dominant role of institutional efficiency and profit, which constrain not only the quality of care, but the very place of care as central to global health and global mental health. Almost every institution of care claims that they give quality care, and they actually produce numbers. What are those numbers about? They are measures of efficiency, institutional efficiency, which is X number of patients at Y cost moving through U system with Z outcome. That has absolutely nothing to do with quality, and indeed, high level efficiency may mean poor quality. Okay? The anti-caregiving bias of our time, I don't think I need to speak to people in this audience. But there are other issues. The picture that I have here is the only time that Picasso painted the head of a medical student, okay? When asked why one eye was closed, Picasso, who was a very clever fellow, said, well, they were going on into medicine. Did you want both eyes closed? We have 8 studies from 8 major medical schools in the United States that show that first-year students outperform fourth-year students in regard to all the important aspects of care. They're not nearly as good, of course, in terms of science and technology that they learned, but they are worse in giving care in terms of taking the history, being attentive to the psychosocial dimensions of care, and a variety of other measures. 8 studies demonstrating this. That means there's something toxic in the training of medical students, that at the same time that they've been empowered scientifically and technologically, they have been de-skilled in care giving, and we should all be concerned about it. Hyping AI and robotics for care. Now, you're hearing this from someone who is actually very impressed with AI and uses AI on a regular basis. There's no question that AI is going to augment medical practice in every field, including global mental health. But we want to be very attentive to the problems with AI. On the 9th of December, the American Academy of Arts and Sciences Committee on AI and the Future of Mental Health, of which I've been a member, will release its report. That report is the first time that the American Academy has a report that has no conclusion and no attempt to summarize. It's simply 15 people giving 15 points of view, okay? On that committee, I came across some very interesting people for the first time, who were psychiatrists and psychologists. I have plenty of friends who are psychiatrists, psychologists, but they also happen to have PhDs in software engineering, okay? And they run major companies, major sections of American technology companies. They're very impressive in their interests, and they say the right thing. But when you actually listen over time and realize what they're trying to do, you know that their objective eventually is to replace caregivers with AI. We have evidence today, real evidence, of the dangers of chatbots as therapists, contributing to suicide, to psychosis, to eating disorders, to a number of other sets of problems. Not surprising, because AI is a set of algorithms. It's a set of statistical processes based on large language models. It predicts the next word, okay? It is not a brain, it is not a human being, does not have a limbic system, does not have affect, does not have moral values, okay? AI in the mental health field is particularly dangerous because it is programmed in such a way as to be compulsive about reinforcement. Compulsive about reinforcement. And this is what's happening today in AI companions. AI companions, which so many young people have today, simply reinforce what that young person says. So if you're saying something that's psychotic, psychotic talk gets reinforced. If you're saying something that's depressed, depression gets reinforced. You're saying something that is suicidal, suicide gets reinforced, okay? And we already have the beginning evidence of the great dangers that lie ahead, but we're going to really see them emerge because the horse has left the barn. The horse has left the barn. Measuring care. We don't measure care. We do not measure care. In order to measure care, we'd have to measure the things I've listed here. If you want quality care, you have to look at the time spent, the quality of the interpersonal relationship, the quality of communication, including listening, explaining, following up, the quality of the physical exam and history taking, the quality of clinical judgment and clinical practice. AI, I believe, will help us measure these things in the future, and this is the example of augmenting the work of clinicians and helping family carers. I believe this is a real possibility for AI if the focus is on what it can do. Caregiving and resource scarcity. In contrast to the medical anthropology and social medicine approach in global health, which emphasizes caregiving, one can identify a public health approach that uses the discourse on scarcity to argue that high-quality care cannot be given to poor populations, and that only prevention can be made available to them. Indeed, this public health approach refers to those who argue for high-quality care as resource insensitive. Zeke Emanuel has particularly made this point. From Paul Farmer's approach, which I thoroughly agree with, the argument for resource sensitivity is an ethical non-starter that presumes inequality is fixed and unchanging, and that economics are more fundamental in value than human relations and care. Paul believed that socialization into the scarcity model was widespread, had to be criticized, and countered with an insistence on care. I think this is one of the things that PIH represents and that the Department of Social Medicine, of Global Health and Social Medicine represents, and the Division of Global Health Equity represents. And we should applaud that, and we should support it. We should do everything to see it advanced, as Paul wanted. So, what happens when care comes first? That's my message to you. I believe that's Paul's message. Care must come first. Okay? When care comes first, what are the consequences of making quality care more central to treatment, policy, and practice? I want you to think about those. What are the consequences when quality care is made fundamental to the training of medical students and residents, but also to community health workers? Not just doing care at the most efficient level, but providing quality care. What are the consequences for technological development and its use in healthcare systems when quality care is used to evaluate AI, robotics, in a sense? Should there be a thing similar to the environmental impact statement, which would be a quality of care impact statement? Think about those things. That's what Paul wanted us to think about. When care comes first for global mental health, how does the primacy of care influence the current practices guiding global mental health? What happens when the cultivation of the practitioner's caregiving becomes the central virtue ethic in global mental health? So this is really a critique of ethics. I gave this, I mentioned this at length 3 weeks ago at Stanford, giving the John King lecture in bioethics there. Our ethics are based on only one aspect, really, of the Aristotelian tradition in the West, and that is principle-based ethics, the importance of autonomy, justice, beneficence, non-malfeasance, etc. But Aristotle had another side that came very much together with the Confucian tradition of East Asia, and that was the argument that ethics is really only in part about principles, but is largely about the moral education of the practitioner. That's what we fail to emphasize in our ethics. Actually, looking at traditional Chinese medicine, or traditional Korean medicine, or traditional Japanese medicine, all coming out of the Confucian tradition, is instructive here. So over the last 20 years, China has had what's known as an Yiwan Guanxi, a doctor-patient relationship problem about trust. And since they don't have a developed medical legal system in China, people have taken it out in terms of attacking doctors and nurses. And indeed, in China, up till about 5 years ago, doctors and nurses were being killed by disgruntled patients who had had bad things happen to them and had no way of expressing it other than taking it out physically on practitioners. That's changed in the last 5 years as China has recognized that problem and responded to it. But this only happened to biomedical practitioners. Traditional Chinese medicine practitioners were never sued, were never attacked, were never powerfully criticized. So what is it that they do that we're not seeing in biomedicine? They practice a kind of slow medicine. They spend time, they explain, etc. All the things that we've known are important to clinical care, but that the structure of our healthcare system has created as a problem. And in this regard, let me just, as an aside, criticize my own generation and the generation that preceded me of physicians in leadership positions in the healthcare system. We have allowed economists to throw the clinical language of care out the window and to see care only as a financial burden. That is one of the important aspects of care, but it's in inadequate way of engaging high-quality care. We should be blamed, I for sure, in this regard, of allowing health policy to develop in our society without a clinical language as part of that policy. A language that allows suffering, pain, and the desire for good care to be as important as institutional efficiency. So one question here is, can primacy of care enable a more adequate development of the fields that are important for global mental health? When care comes first for global health, for global mental health, how does the primacy of care influence the current practices guiding global mental health? What happens when the cultivation of the practitioner's caregiving becomes a central virtue? Can the primacy of care enable a more adequate development of the fields contributing to global mental health? Well, I've tried to do something in this area in a small way. And we have a project called Social Technology for Global Aging at Harvard, STIGA for short. It represents 6 of Harvard schools, including the medical school, but also the School of the Cs, the School of Engineering, the School of Design, the Business School, the Faculty of Arts and Sciences, and the School of Public Health. And what it does is to put together social scientists, design people, engineers, and physicians to develop social technologies for elder care. And we have some extraordinary faculty that participate in this. And what has been, over the 6 years we've done this, so keeps me going at it, even at my advanced age, has been the attention to quality care, making that the focus of collaborative, interdisciplinary work at all stages, from planning through implementation to outcome assessment. So values and caregiving. Paul, Jim, Ann Becker, Salman Khashoggi, and I taught a course carried on now by Salman and Jason Silverstein and one of our other young colleagues. That course we've taught for originally as SW25, then as Gen Ed 1093, for I think it must be 20 years now that that course has been taught. And what has been the most important focus for me comes very much out of Paul himself and the legacy he has left us. That caregiving is not just a professional practice or a family practice. It is an existential act that, actually, Paul should be here reading this to you, that defines our humanity and our relationship with others. It is one of the things that really matters. In a global culture of cynicism and sense of misplaced loyalty, caregiving is frequently perceived as one of the truly worthy objects of ethical commitment. That's broad across societies. Have we taken adequate advantage of the interests of people in quality care, in the value of care, and contributed to it? Have we made care come first? And I end as I begin with Paul Farmer, the most extraordinary person I have come across in my life. He was my student. I gave him his first job in the department. He became my colleague, one of my closest, if not my closest friend, and my boss over time. Paul said two things that you know well, but let me rehearse them with you, because I think they speak to why global mental health is important and why its emphasis on care is important for all of global health. For me, an area of global clarity, of moral clarity, is you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. Or Paul's wonderful words, the idea that some lives matter less is the root of all that is wrong with the world. With a figure like Paul, with a figure like Jim, I think that we have in Partners in Health, in global health and social medicine, and in the division, we have the critical mass to do something about care in the world. Let's do it.
Now welcome Dr. Sheila Davis.
Thank you. Thank you so much, Dr. Kleiman. That was so powerful and so thought-provoking. I'm here as the CEO of Partners in Health and represent 17,000 amazing PIHs around the world, many of whom are in this world today. This has been such an amazing afternoon filled with rich reflections of Paul's legacy, the future of mental health across the US and the world. People everywhere face such serious barriers to mental health care: stigma, poverty, limited access to integrated services, and these challenges are being met through innovative community-led care models that we learned about today. Thank you so much, Dr. Kleiman, for his powerful keynote address. As Paul's longtime mentor, Arthur reminded us how deeply Paul's early work in transcultural psychiatry, medical anthropology, shaped his belief in caregiving, rooted in solidarity, and that this is all central to health and healing. Thank you as well to our esteemed panelists, our moderators, and those who have joined in this conversation today. Paul reminded us that treating a patient means not just caring for the body, but also the mind and the spirit. Mental health conditions go hand in hand with poverty, chronic illness, social exclusion, all these complicating our daily life and recovery. As we think about how best we can meaningfully respond to the global mental health crisis, we must address not only clinical care, but also the social, economic, and structural forces that shape mental well-being. And this must all be done in partnership. PIH integrates mental health in all aspects of our care, prioritizing community social support. Since mental health is shaped by social and economic conditions, our programs are specifically designed to address these realities as well as our clinical care. Our work is strengthened through our strong partnerships with the mental health consortiums, including colleagues in the Department of Global Health and Social Medicine at Harvard Medical School, the Division of Global Health Equity at Brigham and Women's Hospital, and at the Harvard Global Health Institute. Across Partners in Health's 10 countries, we have dedicated mental health teams in all of these. We partner with governments, with policymakers to strengthen systems and to scale proven models. The goal is simple: make mental health care a core part of strong and equitable health systems that reach even the most remote communities. At the center of this work is our community health workers, which you heard about today. They visit homes, identify those in distress, connect those with care, and walk along patients throughout recovery, reducing stigma, and ensuring that treatment is sustained. Through this work, they're showing what's possible when compassion and partnership guide the way. The holistic approach that care comes to, and most vividly in the way that PIH addresses mental health, is much like the care that we do in other aspects of our care, such as tuberculosis and maternal health. In TB, we recognize the profound impact, and you heard about that today, that TB can have on mental health. PIH Lesotho began integrating mental health care into their MDR-TB, or multi-drug-resistant TB program, back in 2017. Every MDR patient is now screened for depression, anxiety, and substance abuse disorders. Additionally, this amazing team, supported by the Cross-Site Mental Health team, provides diagnostic management, ongoing psychosocial support, and this has been prone to dramatically improve the treatment and adherence and recovery outcomes, overall impacting the quality of care. One such patient is a 24-year-old woman who came to the PIH-supported Botshabelo Hospital in Lesotho after weeks of a worsening illness, exhaustion, and was subsequently diagnosed with MDR-TB. Though her physical health began to recover, the emotional toll quickly became apparent, and she stopped cooking, lost weight, and lost the impact of her ability to work with her family. Through PIH's counseling program, she was able to meet regularly with a trained counselor and learn tools to manage her anxiety and reconnect with life. This story, and there are many, many millions more, show us that mental health support should not be considered an add-on to care, but an essential part of care. As we look ahead to the future, one truth is clear: delivering mental health care is not about responding only to urgent needs, but also building the workforce for tomorrow. Every day, PIH's community health-based mental health teams embody that commitment, and we're investing in these teams and through these communities. In Rwanda, as you heard about today at the University of Global Health Equity, third-year medical students complete a dedicated psychiatry rotation, gaining critical skills in compassionate mental health care. In Sierra Leone, there was only one psychiatrist in the entire country. Now there will be two. PIH now supports the nation's first psychiatry residency program, and we're working and fighting for the day when there'll be too many psychiatrists in that country. This program trained the first West African accredited psychiatrist, paving the way for the next generation of mental health providers and making a new chapter of care in Sierra Leone that promises expanded access, dignified and expert mental health care for years to come. As we look at closing this amazing afternoon, I want to invite all of us to reflect on what we can each do individually, collectively, to carry forward the spirit of compassionate care in our own lives and our work. We've heard today how meaningful care changes happens when policy, public health, and advocacy come together, and when we act in solidarity with those most affected by inequality. These conversations challenge us not only to imagine a more just and integrated systems, but how do we build these together? The progress we heard about today shows that transformation is possible. We know that Paul is with us today, as he is with every day. And as the past week, as the Executive Directors and Leadership Council of PIH came together, I knew that Paul was with all of us and echoed in all of the plans and optimism we have for the future. Our call to action is to let that belief guide us, to see as health as a human right and accompaniment as the way that we achieve it. On behalf of Partners in Health, I want to extend the heartfelt thanks to our partners at the Department of Global Health and Social Medicine at Harvard Medical School, the Division of Global Health Equity at Brigham and Women's Hospital, and the Harvard Global Health Institute for their enduring accompaniment and shared commitment to global health equity. I also want to thank the steering committee. It's a thankless job, and the people who work on this for the entire year are truly amazing, and it's really a collaboration between all of these organizations. Your thoughtful collaboration and hard work make this symposium possible. And finally, thank you to all of you who are here, all who are part of the online community accompanying us. We're looking at how we can work together to form and sustain a more equitable world for all of us. It's now my pleasure to invite all of you to join us for a reception in the lobby, and thank you again for walking alongside us today. Thank you.